Hello, everyone, and welcome to today's webcast from the Agency for Healthcare Research and Quality on improving hospital handoffs using AHRQ's Surveys on Patient Safety Culture Hospital Survey. My name is Lisa Huddleston, and I'm a lead research associate at Westat and the communications team lead for the contract that supports AHRQ's SOPS survey. And I'll be your moderator today. Next slide, please. We do have a few housekeeping items. First, if you're having any issues with your computer audio, you can connect to the webcast audio using your phone by clicking on Phone Call to find the dial-in number and meeting ID, or selecting the Call Me option to enter your phone number and receive a call from Zoom. If your computer freezes during the presentations, you can try logging out and logging back in. At any point in today's webcast, you may ask a question through the Q&A icon. We encourage you to share your name and organization or your role when you type your question, and speakers will respond to your questions during the Q&A segment at the end of today's webcast. Please note that both the raise hand and chat features are disabled. You can currently download the presentation slides and view the agenda and speaker bios on our event website at https://events.westat.com/SOPS. In addition, a replay of today's webcast and slides will be made available soon on the AHRQ SOPS website. There's only one Zoom link for the entirety of today's webcast, so if you leave at any time, you can rejoin using the link provided in the email that you received after you registered. Next slide, please. Now I'm happy to introduce our speakers for today's webcast. We're very pleased to welcome Jonathan Bakdash, who is a social science analyst for the Surveys on Patient Safety Culture, or SOPS program at AHRQ. Representing Riverside Walter Reed Hospital are Ashley Hansford, the Patient Safety Manager, and Lauren Murray, the Director of Medical Surgical Nursing. And again, I'm Lisa Huddleston. I'll be moderating today's webcast. Next slide, please. Our agenda today starts with John Bakdash giving a brief overview of the AHRQ SOPS program. Then Ashley Hansford and Lauren Murray will talk about Riverside Walter Reed's patient safety focus, as well as their strategies for administering the SOPS survey to achieve optimal staff response. They will continue the conversation describing how SOPS surveys were used to inform Riverside Walter Reed's initiative to improve handoffs in their medical surgical units. Following the presentations, I'll spend just a few minutes expounding about one of our many resources, the SOPS Action Planning Tool. Finally, we'll end with a question and answer session. So let's begin, and I will hand it off to John. Next slide, please.
Thank you so much, Lisa. Hi, I'm John Bakdash. I work for AHRQ, the Agency for Healthcare Research and Quality. I'm going to give you a brief overview of AHRQ and also a brief summary of the Surveys on Patient Safety Culture, the SOPS program. Next slide, please. The Agency for Healthcare Research Quality, or AHRQ, is a science-based agency. It's part of the Department of Health and Human Services, and we are the lead agency that's charged with improving the safety and quality of the U.S. healthcare system. And as a research agency, we do not have any authority to require the use of any of our tools, surveys, toolkits, or require that anyone submit results to us. We encourage submission, but it is completely voluntary. It is possible there are requirements to use some tools that AHRQ has developed or products, but those requirements do not come from AHRQ itself. Next slide, please. I also want to emphasize that all of the data is voluntary. Again, voluntary data submission, and we encourage that. And the confidentiality of your data is protected by a statute, and this limits how the data can be used. So things like Freedom of Information Act requests, subpoenas, court orders. It's similar to a certificate of confidentiality in a research environment. And when you submit data, you get to decide how you're comfortable in terms of what it gets used for and how, and that's part of the Public Health Service Act. Next slide, please. So a little bit about AHRQ SOPS program. It started in 2001, and it aims to advance the understanding, measurement, and improvement of patient safety culture in healthcare settings. And the SOPS program has developed validated survey instruments and again, voluntary data submission to SOPS database. And really the aim here is to measure, understand, and try and improve patient safety culture and to develop resources to do that. The SOPS surveys are trademarked, which ensures they are valid and reliable and have met certain criteria throughout their development and testing. Next slide, please. What is patient safety culture? So AHRQ's definition of patient safety culture is it's a set of beliefs, values, and norms that are shared by healthcare providers and other staff in an organization. So this helps determine what behaviors are rewarded, supported, accepted, and expected within an organization as they relate to patient safety. And this exists at multiple levels, whether it's a department, the executive level, or different system levels. And that's just to illustrate that in this graph here. Next slide, please. The hospital SOPS 2.0 survey covers a variety of topics. And today the focus is going to be on handoff and information exchange. This is just to give you a sense of the different topics that are covered: teamwork, communication, staffing, and work pace. Next slide, please. So I'm going to drill down a little bit more into the handoffs and information exchange composite measure, because that's going to be the topic covered by Riverside Health today. So in this composite measure, there are 3 different items. The first is about shift changes. Is there adequate time to exchange all key patient information? The second is about transferring patients to one unit or another. The next question is also, I'm just highlighting this one, during shift changes, there's important information often left out. What you can see here are the results from the 2022 survey with the percent of positive responses. You can see 71% positive responses for all hospitals that submitted for the first question. It's lower for the second question, and in between for the third question. And this is all of the hospitals that submitted, 400 hospitals from the 2022 data. Next slide, please. So I just want to give you an overview of the database report from the last cycle. And a benefit of participation is every hospital gets a private feedback report. So teamwork was an area of strength, as was support from supervisors, managers, and clinical leaders for patient safety, whereas an area for improvement, on average, for most hospitals was staffing and work pace. And there's also more detailed informations with breakouts. It's my pleasure to hand it off to Ashley Hansford and Lauren Murray from Riverside Health. Thank you so much.
Thank you all for joining us today, and thank you, Lisa and team, for having us. Lauren and I are really excited to be here to share our journey around handoffs with you all. So to start, we would just like to share a little bit about Riverside Health System and the services that we deliver. Next slide. So Riverside Health System consists of 5 primary markets regions that covers 8,000 square miles of community served. We have over 9,500 team members and 750 plus providers. But most importantly, Riverside Health is a large family of compassionate teams who care for others as we would care for those that we love. Next slide, please. So Riverside Health offers a continuum of care that ensures patients receive comprehensive support at every step of their healthcare journey. Services range from acute care, primary care, specialty, emergency services, rehabilitation, mental health, and preventative services. We also have Riverside School of Health Sciences and an amazing foundation that helps bridge gaps and needs for our patients and team members. Next slide. So Riverside Health consists of 4 acute care facilities, with the 5th planning to open in Smithfield, Virginia in early 2026. We are Riverside Walter Reed Hospital, and we're located in Gloucester, Virginia, and we're at the top center picture of this geographic circle here that you see on your screen. Next slide. So for us here at Walter Reed, we're 67 licensed beds. We serve 5 counties. We are a Leapfrog Grade A recipient. Very proud of our CMS hospital rating of 4 stars. We do have our Pathway to Excellence designation, as well as being chest pain accredited. We are also recognized for Get With the Guidelines in 2023 and 2024, along with being a primary stroke center. Next slide, please. So commitment and accountability to quality and safety are foundational principles for Riverside Health System. Our leadership at all levels, from system level board, C-suite, facility level boards, are all actively engaged in supporting quality and patient safety initiatives, ensuring that we continuously improve our processes and outcomes. Facility level goals are driven off of our overall system commitments to ensure we are aligned to achieve our overall system goals that support quality and safety. Next slide. So we do believe that a robust safety culture is the foundation of safer care and improved patient outcomes. We can see how our overall patient safety score aligns with our increase in our quality outcomes, which is demonstrated here in our leapfrog score. Next slide. So we measure our culture of patient safety by participating in the AHRQ survey on patient safety. We typically do this annually in the fall. It's open for approximately 4 weeks. And we do participate with the acute care survey, as well as the lifelong health and the medical practice survey. Next slide. So obtaining participation starts with system level messaging and partnerships with the marketing team to maximize the use of our intranet. Communication begins from our health system CEO, Dr. Dacey, from our system vice president of quality, Terry Sievers, and all of our hospital presidents. And then that messaging is sent out via email weekly and a health system newsletter, as well as on our intranet site. Next slide. So we then use the system level messaging to create focused facility level messaging that continues to engage the frontline in conversation around safety and grabs interest in the safety survey. We heavily focus on communicating with the previous survey feedback allowed us to achieve while we're rounding, and then also asking the frontline to please help us continue to improve our efforts and our commitment to high reliability by continuing to share their safety feedback through the survey process. We update the front line weekly with participation rates where we are compared to our other acute care facilities. And we really leverage that healthy competition between each other, and it makes it, a little bit fun. So as an incentive, team members can also share when they have completed the survey for a raffle ticket. And we do really fun, trendy raffle prizes. It's no pressure and completely optional. Since this survey is confidential and anonymous, so they can choose to participate in that piece if they would like. Next slide. So overall, I'm not too proud to beg in fun ways, of course. So using Stanley Cups last year was very successful in getting some engagement around the survey. And then everyone really enjoys getting the weekly email of who won the raffle prizes, having QR codes to be able to scan to easily take the survey, and then just continually communicating through all of our mediums of communication that we use as far as email, our closed private Facebook pages, our visual mission boards, rounding, our daily unit and facility safety huddles. So we just communicate, and then talk to our teams for increasing that communication or that participation. So this is a spreadsheet that I built and began using in 2021 as I was looking for a way to see the big picture with our patient safety culture survey results. So when you get the results back from the survey, it's simply the results of that current year, that moment in time. So having a spreadsheet to keep up with over the year over year was critical in order for me to deliver information to our leadership team that had meaning and value versus just the current result number. So trying to really tell a story with that data. So we track our year over year scores by composite for the overall facility, as well as the overall patient safety rating and participation rate. Next slide. So I used the same data method for departmental level results. And I know that this is a really busy slide, but just kind of wanted to share the overall picture with you all. Because again, this allows me to see the big picture and the specific focus department areas. This allows us to see high-performing areas and interview them to determine what are they doing or what have they established to be able to have such success so that we can share and extend those best practices across all of our teams. So following that, I meet with each department leader one-on-one to review the safety survey results, and then we discuss the successes and opportunities together. I then build each leader a PowerPoint specific to their area with what we discussed in an easy-to-read, visually attractive format for them to be able to then deliver the results to their frontline teams. The leaders then, deliver and discuss the results with their teams, and their departments get together to determine what they would like to focus on as a group. As far as open comments, we share comment trends with the frontline, not word for word. And then when there are open comments reflecting physical safety concerns, like things around building safety, workplace violence, we incorporate that feedback into our facility level workplace violence committee for discussion, and then formulate feedback and actions for those concerns. And then we put out a general update to everyone. The leaders then close the loop with me following their unit meetings. And then they share with me their presentation, if they made any changes to it for what I sent them, feedback from their teams, and a sign-off attendance list. This is an important piece when maintaining our documented evidence for Leapfrog, and being able to share how the feedback was delivered to the front line, and then what response the front line had to those results. And then again, also all frontline nurse-driven work is also captured for supporting documentation for our Pathways to Excellence designation. And then all of the results are packaged and presented to our facility level board, service line committees, and our facility level leadership team. And then all data is then packaged in our annual patient safety report and our annual quality report. Next slide.
All right, so now we're going to look specifically at our Med-Surg department. So our system identified handoff processes as an area with the greatest opportunity. So upon reviewing our facility's handoff practices, we found the need for potential enhancements in various departments. However, as a young team and the largest inpatient department, we chose to focus our efforts on the Med-Surg unit. Using our event reporting system, we identified several safety incidents that could have been avoided with a standardized and more effective handoff procedure. In addition, there were concerns around nurse readiness for IPOC or interdisciplinary plan of care rounds. So here you can see that during shift change, important patient information is often left out. It was one of our lowest scores in 2021 at 35%. And we saw little improvement in 2022 with 38%. Next slide, please. So with that information, we utilized the AHRQ action planning tool to structure and guide our handoff body of work. The SOPS tool provides a clear framework for identifying specific areas for improvement, setting measurable goals, and then tracking your progress. This structured approach allowed us to align our team's efforts, ensure accountability, and systematically address the challenges in our handoff processes. Overall, this tool enhanced our focus and effectiveness in implementing this change. So our focus was handoff, specific to the information exchange on Med-Surg from shift to shift. Our SMART goal was to improve survey on patient safety. During shift change, important patient care information is often left out, from 38% in 2022 to 61%, which was the benchmark in 2023. Next slide, please. Our initiative was to develop a standardized handoff tool for RNs to use for shift-to-shift handoff on Med-Surg. So you can see the resources required to include people, time, supplies, and equipment. And at the bottom of the screen, you can see the top two barriers that we anticipated. Number one was frontline team engagement and active participation. And number two was leadership ability to drive sustainment and expectation of that handoff tool. So our strategies for overcoming these barriers were: one, to empower our nurse-led shared governance council for frontline engagement to drive this change, and two, clear and consistent communication to connect the team back to the why and update on progress supporting continued inclusion in this decision-making. Next slide, please. Page 3 of the action plan assisted us in organizing our success measurement criteria, determining the starting point for the pilot test, and establishing the timeline for implementation. You can see our process measures were preparedness for IPOC, spot checks or random audits, frontline feedback, and open discussion as a standing item on our unit meeting agenda. Our outcome measures would be the handoff questions and the AHRQ survey on patient safety, specifically focusing on shift changes on med-surg. At the bottom, you can see our timeline with a plan for ongoing monitoring and auditing. Next slide, please. Page 4 of the action plan guided us in developing a communication strategy, identifying the platforms we would use, and outlining how we will share updates on our progress. We included our Riverside Walter Reed nursing leadership and case review teams in the action planning and progress updates. We used various forms of communication to include our nursing leadership meetings, safety huddles, shared governance, unit meetings, our visual mission board, email, and our closed private unit Facebook pages. We provided updates on progress weekly, monthly, and quarterly through case review, unit meetings, and our inpatient service line. Next slide, please. We collaborated with the shared governance team on nurse-led initiatives and practices. We created a threat versus opportunity matrix to identify shared needs, which you can see here on the slide. We researched best practices and facilitated shared learning with other Riverside Health System facilities and external nursing units regarding tools and methodologies for clinical handoff. From this, we developed a draft for a paper handoff. Shared governance reviewed and refined the draft before presenting it to their colleagues. We then conducted a trial of the new tool, making improvements and integrating it into our daily standard of work. Next slide, please. After interdisciplinary input, individualized feedback, reworking the layout several times, and a series of edits, we have developed this med-surg handoff tool. And I am incredibly proud of the time and thought that was put into this tool to ensure that we met the needs of both our patients and our nurses, focusing in on some of our unique opportunities here at this facility and on our med-surg department. I'm here today simply as a spokesperson for the amazing team of frontline nurses behind this tool. I by no means take the credit, as our clinical excellence shared governance really laid the groundwork with Ashley's support, and then our med-surg team tweaked and fine-tuned the layout and the content. Our nurse manager, Ashlyn, and I then jumped in to ensure consistency and accountability, but the kudos and gratitude really goes back to this team. Their initiative and investment is what made this an incredible project and truly why I believe we achieved such success with our goal. Next slide, please. Throughout this initiative, we recognized the importance that communication was clear and delivered in multiple methods to hardwire this new process and expectation for our teams. As their leadership partner, I wanted to prioritize transparency and empowerment. So through transparent discussions, we recognized a significant gap in information exchange. And through empowerment, we were able to challenge our nurses to take ownership of their practice and to sit at the decision-making table in developing a resolution. We worked together to identify expectations, and while my focus for communication was around consistency, I encouraged shared ownership and peer-to-peer accountability. Our nurse manager, Ashlyn, and I spent a lot of time providing individualized feedback, both positive and constructive. Next slide. We measured significant quantitative improvement in our 2023 survey on patient safety, where we observed a 30% improvement for handoffs and information exchange overall. The most impressive, and what I am so proud of, was the 76% improvement around shift-to-shift handoff, achieving 67% in 2023, or 6% above the benchmark, which exceeded our initial SMART goal. Next slide, please. Anecdotally, interdisciplinary perspective and feedback has been overwhelmingly positive. While change can be uncomfortable and it does take time and repetition, the overall long-term benefits of this initiative are observed by all disciplines and celebrated daily. Not only is the content of information exchange appropriate, consistent, and relevant to the patient, but the delivery is smooth and thoughtful and logical. This tool has supported a streamlined approach to IPOC, eliminating duplicate efforts and supporting more time at the bedside with our patients. Overall, team member involvement has increased empowerment and investment in the outcome. Next slide, please. So what does future state look like? We are in the process of adapting this tool for our intensive care unit, following a similar format and flow, but recognizing that content and spacing may slightly vary due to the complex nature of a critical care patient. Concurrently, we will be adapting a similar tool for CNA, PCA, and unit secretary handoffs for consistency within our department. Next steps would be information exchange interdepartmentally with the end goal of a uniform clinical handoff throughout our facility, in hopes that the way you give report is the same way you should expect to receive report, requiring investment and input from all departments to determine what does great look like to you. So thank you. That does conclude our presentation today.
Thanks, John and Ashley and Lauren, for those informative presentations. You've shared quite a lot of helpful information in a small amount of time about your use of the SOPS surveys. So now I'd like to kind of briefly provide an overview of the SOPS action planning tool. Next slide, please. So after you've analyzed your SOPS results, you can use our action planning tool to assist you in developing an action plan based on your SOPS results to improve patient safety culture in your organization. The action planning tool is designed for all survey settings and provides step-by-step guidance to help survey users develop an action plan to improve patient safety culture. This tool includes an action plan template that your organization can use to identify your patient safety culture areas for improvement and to document goals and initiatives, needed resources, process and outcome measures, and timelines. Next slide, please. As you saw with Ashley and Lauren's presentation, here is a page from the action planning tool to assist you with implementing your improvement initiatives. It's available in both Word and PDF documents formats on the AHRQ SOPS website. The document poses some key questions and it provides space for your notes and for your answers. Next slide, please. The action planning tool takes you through a three-step process to guide improvement. First, identify areas to improve and then develop goals that are specific, measurable, achievable, relevant, and timely, otherwise, as we know them, as SMART goals. Second, plan your improvement initiatives as you implement that initiative. You can use SOPS benchmark data and then re-administer the survey in 6 months, a year, or longer to determine whether the initiative has improved patient safety culture. Third, communicate the plan within your organization through many communication channels. How will you share that plan? It could be through meetings, it could be through emails, it could be through flyers, maybe also newsletters. You can access this three-step process, the action planning tool and the Word and PDF templates through the AHRQ SOPS website at https://www.ahrq.gov/sops/planning-tool/index.html. Next slide, please. All right, now it's time for the question and answer segment. Our speakers would be glad to field some questions, and I believe we do have a few that have come in. Next slide, please. As a reminder, you may ask a question through the Q&A feature shown here. Look for the Q&A icon. We encourage you to share your name and your organization or role when you type your question. And if you joined late, a replay of today's webcast will be made available on the AHRQ SOPS website. So let's get to some questions here. All ready to answer. So I'll start with you had began your presentation talking about being able to get some buy-in or working with your leadership team. How did you get the leadership team to really recognize and treat this issue as an improvement priority?
Well, to be honest, it really all starts with culture. So our leaders are incredibly focused on risk-based thinking here at Walter Reed and within our health system. So when there's data signifying an opportunity that matches what they're also hearing on their units and from their team members, it really didn't take much convincing. It's just the survey data really just reinforced that we have an improvement area that we need to focus on. And then our team members sharing with us gaps that impact care delivery from that handoff, and just being really open to hearing it. So really, to be honest, there wasn't much convincing, as more of a partnership to just be really open to, and be okay to know that we have an opportunity that we need to improve. It just takes us all together to fix it.
Okay. Okay, good. This is from Jennifer. Do you administer a separate employee engagement survey that may include safety-related items? And if so, how have leaders reacted to having a separate survey specific to safety culture? Just wondering if you've had leadership concerns around pulling people off the line multiple times to fill out surveys.
No, so historically, our employee engagement survey is in the spring, summer, and our patient safety survey had been in the fall. And the employee engagement survey, I mean, there are some safety questions, but not like what's asked on the AHRQ safety survey. So, different information. And then our leaders are always really supportive of getting that feedback. I mean, we really want that feedback because that's what helps us drive our action planning for, the next year. So no, we're just being open to doing those surveys and getting the feedback. And then we also will allow, we have the barcode scans. So team members can do it from home, from their phone. If they did it from home, they can write that in the wrap book and get paid for the time that they did that survey. And we also offer like quiet conference rooms with a laptop computer that they can slip out to. And our leaders will even cover their patient load on the clinical units for them so that they can step away to take that survey.
Okay. So talking a little bit about incentivizing people to take the survey, can you explain again just how you offer the raffle when it's an anonymous survey?
Sure. So it is optional to participate in the raffle because it is anonymous. So you do have to just send me an email or come and see me and say, hey, I completed the survey. I'm here to pick up my raffle ticket. It is really honored based. If somebody tells me that they completed the survey, I give them a raffle ticket. And our participation rates are really great, over 70% participation rate. So I truly believe that everyone is, really completing that survey. So if they would like a raffle ticket, they can certainly tell us that they completed it. And then if they're not comfortable with that, that's okay too.
So we have a question here from Jeff, wanting to know if the way you administer the survey, do you administer it internally or do you use a vendor?
We administer it internally.
Mm-hmm.
And we have data scientists in our health system quality department that help with that.
Okay. Another question is, how has your improved handoff process, if you could talk a little bit more about this, really impacted your outcomes? And specifically mentioned was like medical errors.
Yeah, well, I can say that so while we had our opportunity with handoff that was noted in our survey results, we also do safety event reporting. And some of the things that we would see frequently are lines not traced at the bedside, confusion or questions about medication, are things that if we had had a solid handoff tool and we did that bedside shift report effectively, those could have been prevented. So I don't know if you have anything you want to add to that, Lauren?
No, yeah, I think that, like she said, looking at our cares, and we had identified there were certain things that we were missing, and it was very clear what those things were. And so we used those findings to build our tool. So while our tool is very tailored to Riverside Walter Reed and even med-surg specific, so other facilities may want to look at what their fallouts or opportunities are, and when building a tool like this to really tailor it to their specific needs. So you know, with documentation of intake and output, that was an opportunity for us. So we made sure that we had a specific area for that where it was very clear what the expectation was. So I think that, you know, again, like I said in the presentation, the way you're giving report is the way you're expecting to receive it. So we're kind of following the same format, running down that same line. And so we're getting all of the same information at the start and end of each shift.
Now, you talked a little bit about the incentives to try to get the response rates up. Just wondering, did you have any pushback at all from staff as far as time available to complete the survey?
Yeah, so, and I'll let Lauren kind of piggyback off of this, but with change, anytime you have change, it's going to create some hesitancy and some anxiety, you know, in your team members. But one of the things, it really wasn't an added process. Our team members had all created their own handoff tools based on like what they felt was important to hand off. So it's not that they had to then start using a paper tool. It's just that everyone was using something separate. So the information flow wasn't standardized and given and received in the same way. So I don't know if you.
Yeah, no, I think you said it perfectly, but I think when we built this tool, because it was built by the bedside team, we took bits and pieces of what everyone was already using. I think we found the best parts of everybody's individual tools and built one solid tool that met their needs, met our patients' needs, but then also met the facility needs as far as where we had fallouts. So I don't think that, while again, like Ashley said, change is uncomfortable, absolutely. And there was a period of time where it was a lot of repetition, a lot of follow-up. And I think that's where leadership has to step in. There has to be that consistency. But once we got the tool in a place that was really what the nurses needed, I think that's when it really clicked.
Yeah, because, you know, people were really attached to the tool that they liked, you know, so that was a little bit of a challenge at first, but with everyone's input, I mean, it really came along. So
regarding this tool, is it the same piece of paper given shift to shift and things are added to it then?
Correct. So we write in pencil and we erase and update as things change. And that way they're not having to rewrite each paper at the start of every shift. It's passed along. So labs, we've left space so that they can show how the labs are progressing. And it like I said in the presentation, it's really nice in IPOC when they can paint the picture of the last couple of days leading up to their shift and how they assess that patient today.
Okay. So we've talked about how change can be hard and such. So how did you work with staff members who were giving and receiving a report and they were resistant to the change?
So, like I said, consistency was really important. So one of the ways that we were auditing the use of this tool was through IPOC. So myself or our nurse manager, Ashland, would sit in IPOC or do sit in IPOC every day to ensure that the tool is being used. If it's not, instead of coming at it punitively and attacking that team member, we were approaching it from the standpoint of what are the barriers that are keeping you from using this tool? How can we make sure that this tool is going to work for you? And we got really good feedback. And once people realize, like, gosh, if I, you know, share what I think about this tool, they make changes and we get to edit and tweak and really make it work for us. And so the more people opened up, the more information we got, the more we tweaked this tool. I mean, I can't count how many versions we've had, just making sure that it really met the needs of our team. But I think just kind of meeting them where they are, identifying those barriers, and then together finding that resolution, letting them own it.
yeah, I mean, it's a journey for sure. Like we even updated our tool
Last week.
So,
Yep.
I mean, it's an ongoing, evolving, you know, process.
Well, speaking of just evolving, is this a tool that is specific to nursing or has it been developed for other departments such as like patient transport?
So that is our end goal. We're kind of in the works of that. We're starting with our ICU, recognizing that it'll look fairly similar, but have some differences just based on the needs of that patient population. We're also in the works of kind of adapting a CNA or support tool. Wouldn't be quite as in depth, of course, because they're going to have a larger patient assignment. But making sure that the look and flow of the forms align so that, again, we're all kind of, marching to the same tune, right? So yes, that's absolutely our end goal. We haven't gotten to transportation yet, but that's certainly in the future for us.
Okay. On that note, what about physician participation? How's that going as far as engaging physicians?
Yeah.
Yeah, so every year, we work a little bit more to get some more physician participation. But this past year, our CMO, Dr. Melvin Shursky, partnered with me in communicating to the providers and talking and speaking about it at the service line. So we ended up having about 12 providers complete the survey last year, which we're a small hospital, so that's a good number for us. Much better than where we were historically.
Okay. I have a comment from an attendee here. Our survey went out house-wide, so I was thinking that our goal had to be house-wide also. But I like how you picked just med-surg for your year one and then moved on. Did you have any negative feedback from starting with a narrower focus?
No, so anytime that you're looking at performance improvement, especially with something like this, we feel it's really important to start small and focused and do that PDSA cycle. So pilot it, test it, work out the kinks, and then enhance and expand and share, kind of like what we're currently doing now, moving towards ICU. So I think sometimes we do feel like we have to do it in every area, but you can't always boil the ocean successfully. So making sure that we're doing bites that we can manage and positively impact, rather do it slowly and confidently to where it is integrated into our daily standard work than to try to roll something out for every department at the same time.
Okay, yeah. Had an interesting question here. Do you have any suggestions for what can be done if the survey results after 2 or 3 survey administrations are consistently the same?
So I think that what I do here is I look at that year-over-year data in a spreadsheet that works for me to be able to see the big picture and really aligning what you want to do with where your culture is. So kind of meeting everybody where they are and then pulling them to where you need them to be. So I think starting with conversations with your administrative team, talking about what you're seeing, what changes may be able to impact that. When you go to have that conversation, talk about some of the tools and resources that are outlined in the resources toolkit that AHRQ has that impact the different domains and areas. And then talk about how you all can get there as a group. But then it's, making sure that you're following that action plan and you're having the check-ins and there's the accountability and that there is an expectation that we do something with the information that we're learning and we keep continuing on that.
Yeah, exactly. Another good question here, is your handoff tool embedded in your electronic health record? And
So
similar question. Go ahead.
Oh, sorry. No, go ahead.
Yes. And similar question that also asks, is the handoff form and the information entered into that record?
So the information that is on the handoff tool does come from the medical record. There this specific tool is not built into Epic yet. We do use Epic here. We call it iCare. There are handoff tools that are already built into iCare. They did not encompass and really have the level of content that we needed for where our team members were. We have a lot of new grads on our med-surg unit. So also trying to meet them where they are. But I do know that we have looked at an electronic tool. And when we get to that point as a health system, I'm sure that we'll be able to make some impact there.
Sure thing. Okay, here's actually a question for me. Where can we find the action planning tool so we can change our culture to just culture? The action planning tool is available on the AHRQ SOPS website, along with many other resources for being able to administer the SOPS survey. And there is a link in the slide deck. So if you go to the event site and pull the slide deck or pull the slides here pretty soon on the AHRQ SOPS website, then that should be able to direct you. So, how are the managers on the floors holding staff accountable for their handoff reporting?
So, like I said, you know, we talk about it. We started talking about it daily in our safety huddles, making sure that it was very clear what the expectation was and the ask from not just from us, but from their teammates, their peers, because the survey was telling us that our team members were not getting the information that they needed shift to shift, and so we needed to find a resolution. So, when our Clinical Excellence Council did that, we brought that to the team and basically said, you know, this is what we have identified. This is how we plan to address it. And your teammates, your frontline team members have developed a tool. And so we need your feedback. We need your support in making this tool our daily standard of practice. So like I said, we got lots of pushback in the beginning because change is uncomfortable. But the more that we tweaked it, the more the original tool that we first rolled out looks very different than what we're working with today. And that's amazing. That's perfect. That's what we wanted, because we wanted the team to really go in and personalize it and individualize it and make it what they needed. So each day in IPOC, when we saw that people were still, sometimes we saw they were using our tool and then behind they had their own form, and that wasn't the end goal. The end goal is that we're eliminating duplicate efforts. We're not adding to your workload. We're making this a more streamlined process for you. So afterwards, we didn't, do it in front of the group, but afterwards pull them aside and say, hey, I noticed you're still looking at your own notes in the background. What can we add or change or do differently in this handoff tool so that you don't have to do that? Because we don't want to add to your work. We want to make this more streamlined. So we got really good feedback when we approached it that way. We never had to take that next step as far as accountability goes and with disciplinary action, but certainly we were holding that team to that expectation. If we had people that continued to repetitively were not compliant, then we would have followed counseling and education and disciplinary action, but we really didn't want to get to that point. We do have a great team, and I think because we allowed them to drive this change, we never had to go there. So we've got a great team, and I think that we had great partnership with Ashley. I think her role is super important for the leaders, and from my perspective, just having that partnership is really important.
Yeah, when you think about the team members that weren't using the tool and the way that Lauren and the leaders came at it and addressed it, is no one is intentionally saying, I'm not using this tool because I want to be defiant, right? Like, we're not a group of children. We come to work, we want to take care of our patients, we want to do the right thing. There's a barrier, there's something missing. So why is that person not using this tool? And we have to learn that to make it something that is effective for everyone. So just, really remembering that it's not a negative thing. There's something missing. There's a reason it's not being used. So let's learn why.
Okay. This is kind of going back to the communication about the tool. I believe you had mentioned this in your presentation as far as the QR code. You were using QR codes to complete the tool. Did you find that extremely effective as far as people accessing it that way?
Yeah, so we use the QR code to complete the safety survey.
Oh, okay.
from their phone, but not a QR code for using the handoff tool.
Okay.
Yeah.
I stand corrected. So, yeah. Um, so I had a question here. How do you plant the seed to prep staff prior to launching that second survey, the re-administration of the survey, in order to encourage participation so you're not getting pushback like, well, didn't we just do that?
Yeah, so I think it all comes down to communication and then making sure that that communication isn't just at survey time. It should be, incorporated into everything that we do every single day. We should be having conversations about safety. So, making sure that we continually highlight efforts and changes based off of that feedback throughout the year, not just, okay, we did this, we can check this box and now move on to something else. It's a continual show of the work that they're doing. So making sure that we keep that engagement with safety all year, not just at a certain time of the year. And then making sure that we do highlight, a couple weeks before the survey launches, all of the great catches that we, were able to celebrate over the year, some of our accomplishments, remind people in all departments about what everybody achieved throughout the year. So that they can see, oh, the lab did this impacted us, and really kind of connect those dots for them for when they go to take that survey, that we've kind of planted those seeds in there. But really just making sure that it's embedded in what we do every day, every conversation, every unit meeting, every huddle.
Part of your culture.
Yep, part of the culture.
Definitely part of the culture. Did you have any logistical barriers that you had encountered in the administration of the SOPS survey and in carrying out the handoff initiative?
So, of course, someone else mentioned, time on here, but time, it can always be a little bit of a barrier depending on your census and what's going on in your units. And people feeling like they have to be rushed or don't have the time. So making sure that we just provided the avenue for them to be able to take the survey without having to feel rushed, covering their patients, talking to them about it, and encouraging, that we want that feedback.
Yeah, I think for the med-surg nurses, having that uninterrupted time and some space from your peers and the call bells and the bed exit alarms, just having that quiet time to complete that survey and be thoughtful about it is really, really important. And just knowing that leadership supports that and prioritizes that, I think is key.
Yeah. So like during our survey, Lauren had set up the med-surg conference room right on their unit to have a laptop in there so anyone could go in and shut the door during their shift when they had their patients covered and sit down and take it. So it's making sure the avenues to do it are there.
How do you ensure that your frontline associates really feel the changes that have resulted from their engagement in the survey?
Transparency, talking about it, celebrating it, highlighting team members who have driven that work so their other peers can see the work that's happening. And then making sure that we use the data that we have to tell the story to them.
Yeah, I think Ashley does a really nice job of putting this information, this data in a format that makes sense to the team. I think if you throw all the numbers at them and the busy slides, it's really hard to interpret. But I think giving it to them in a way that makes sense and is meaningful and really, feels closely connected to the work that they do is really important. I think she does a really nice job of that from my perspective, and I appreciate that because that's not a strength of mine. So I think that's important.
I think it's tying the data piece back to, well, what does this mean for me? What does this mean in my work? How did it change my work? So how I talk about it or give Lauren information to talk about it to med-surg, is different than the way I give our lab director the information to talk about it to her team. So it's like, how is it impacting my specific work so that it is meaningful and it can align with what I'm, my train of thought and what I'm thinking.
Okay. So do you see like a morale, a morale booster from just what you've, the results that you've realized?
So we haven't necessarily been able to tie it back to our engagement survey. That is something that I, asked our HR department about to see if there were any triggers from this implementation that we did that we could pick out from our engagement survey. But I mean, overall, I think that our team members are really comfortable talking to us and sharing feedback.
Right.
So I feel like we would know, but again, you don't always know, but so
Yeah, I think we do a nice job of celebrating wins, small and big. So I think we try to highlight the good work that's happened throughout the year as it happens, and have those sometimes difficult but very transparent conversations. And I know from this, particular initiative, one of the best avenues of feedback and celebration that I've given our team is from the providers. I mean, their feedback on the growth that they've observed in our team members through their IPOC presentations. As a nurse, I mean, it feels great to hear that feedback from your hospitalist group, that your presentations are greatly improving and you sound confident and you know your patients so well. I mean, that's a great feeling. So I think we always try and share that feedback and make sure that that's at the forefront, celebrating the team members and encouraging them.
Okay. And I'm looking to see if there are any more questions. I think I did have one asking about, yes, are we able to get hard copy of the presentations? Again, I think that's a question for me. We will have the presentation slides on the AHRQ SOPS website here in just a few weeks, or you can visit our event site also that was mentioned at the beginning of this webcast. So we are coming up on the top of the hour. So I will kind of move on. Next slide, please. Okay. I want to thank everyone, Lauren and Ashley, thank you so much, and thank you for bearing with us as we asked all these questions. I do appreciate it, and everyone who has attended today, our speakers, the attendees, very, very good information in this particular webcast. A brief webcast evaluation will pop up when you close out from today's webcast. Please take a moment to provide us with your feedback because it helps us. It helps us to improve our offerings to you, to find out what you want, what kind of topics we should cover, and to really be able to plan future events that truly meet your needs. So thank you again, everyone, for joining us. And this concludes today's presentation.